as a kid, I was in the hospital probably 20 to 30 times a year just for my asthma until I was about 10 or 11.
Hello, all my wonderful Courage, Confidence, and Connections podcast fans. I'm Janice Debo, your host for my show. My guest today is Eugene Manley. Welcome, Eugene.
Thank you. Good afternoon. Thank you for having me. It's a pleasure to be here.
Well, I'm delighted. It took a while, but we got you.
Yeah, finally, we had some hiccup with timing back and forth, but we made it happen.
We did. Well, if you would tell our wonderful audience a little bit about you, and we'll get into some details on the business stuff, but just, who you are, where you are, and a little bit about you personally to start with.
Okay. I am Dr. Eugene Manley Jr., and run I'm the founder and the CEO of the STEMM and Cancer Health Equity, or SCHEQ Foundation, which is a nonprofit that I founded with the goal of increasing STEM workforce diversity and improving outcomes for underserved populations navigating the cancer care continuum. By training, I'm a mechanical engineer, a biomedical engineer, and a cell and molecular biologist that has done a lot of work in musculoskeletal biology, biomechanics, and cancer biology, in particular lung and breast. But I grew up in Detroit, very poor as a first gen scholar. And so I was the first one in the family really to navigate a lot of these spaces and, navigating academia, navigating the PhD, navigating the postdoc, navigating the nonprofit space. And then after I left the postdocs, I went to 3 nonprofits before I launched my own. And part of the work I do is inspired by the fact that, growing up, we didn't see really many people in science fields when you're in the inner city. And a lot of kids that come along don't get that exposure to science at early age, or see people that look like them at early ages in STEM fields. So they don't know they can go into these spaces. And then lastly, we just have so many just issues of how care is delivered to diverse and poor and underserved populations, as far as, people not knowing how to read medical charts, people not having things explained to them. And so I do a lot of work on trying to break down these information silos, trying to provide information and resources to empower people to advocate for the care they should receive. And then we try to address disparities and inequities. Primarily, we focus on lung, but we do broader educational stuff.
Fantastic. That's a mouthful. I'm glad you said that instead of me.
I could have shortened it for you if you wanted me to.
Not at all. I always want my listeners to know as much as possible about my guest. Well, tell me, what was it like growing up for you, and what did you do for fun as a kid, and did it have any impact on your life now?
Ironically, I was a bookworm and a nerd as a kid, ironically, I was also a chronic asthmatic and I had anaphylactic allergies, and I still have both today. But as a kid, I was in the hospital probably 20 to 30 times a year just for my asthma until I was about 10 or 11.
Wow.
And I have a lot of seasonal allergies. I still have them. I'm actually not on allergy shots, would have helped. But I still have the real strong anaphylaxis to just the odor of fish, seafood, and shellfish. If I'm around grass, like freshly cut grass, I will start wheezing like crazy. So my summers were not a lot of fun. I could not be outside very long because then I would just get sick out of the blue. And to a degree, cats. If I'm around a cat and they're not clean and just the dander, then I'll start wheezing. But otherwise, that's kind of grown up. But I was always, maybe because I was in the hospital so much, I got interested in science and medicine. And then when I was a kid, which be admitting how old I am, Transformers came out. So I used to watch those, and I always want to know how things moved and operated. And so I think just that laid the foundation, the engine, the Transformers, and then the hospital just sort of laid a foundation in my head, probably for a career in science and engineering. And then it became patient advocacy, just all the things I observed.
Well, it makes sense that being in and out of a hospital around that environment, that you would pick up the interest, because you wanted to make things better for people, I'm sure, because of what you've been through. And I know you're going through some more stuff right now. Tell me and our audience where courage may have come into play with you because of some of the things that you've been through and done. Were you needing to bolster courage to get through some things?
For me, it wasn't so much about bolstering courage. I was always a resolutely stubborn and independent. And so I think I rubbed a lot of people the wrong way. A lot of people were like, well, why are you always in the books? Because I want to be. And I was the one who would always question, well, why are we doing this? And why are we doing that? And why? And I just had a fundamental sense of right and wrong. And I would be the one that always, I wouldn't question authority. I just would, why is this way? And why does this rule in place? And who is this helping? Who is it benefiting? And I used to get teased a lot as a kid because I was called the nerd, the sellout, and I spoke quiet, and that's what they said. And I was just like, I'm going to do my thing. And so, and then even in my elementary school, I just forgot I remembered this. I was the first boy in that school that tap danced, and I got teased mercilessly for that. But I just did it because I wanted to. And I think maybe, I don't know, maybe after some point after high school or in college, I went back and the teacher just thanked me. I said, I didn't do anything. She said, you doing it made the door open for so many other kids. And now I have too many boys in the class. I'm like, I really didn't do anything. I was just doing what I wanted. But I think that laid the foundation that I was just going to go to the beat of my own drum. So I never waited for other people for validation or acceptance. So I just do my own thing.
Yeah, well, that's great. And you're still doing your own thing. So,
Yes, very much so.
so really, you're growing up. It didn't hurt your life that you were a nerd and you decided to
No.
dance. Do you still dance? I know you've got an injury right now, but do you like
No, I mean, I hadn't tap danced since elementary school. In my college days, I may have gone clubbing here and there, and I may have been on a speaker, but I'm kind of a little bit too old right now to do that anymore.
That's funny. Oh my goodness. And you grew up in Michigan,
Yep, in Detroit. Yep.
in Detroit. Well, I've been to Detroit. I really enjoyed going to the Ford Museum when I was there.
Yes. Yeah, I grew up there, spent my summers in southern West Virginia, probably till I was about 10. So
Really?
that's where my grandparents were from. So we go every summer until they got moved up to Detroit. And when you're a kid, you think, oh, we're going to see grandparents. We're thinking it's a big city. I'm like, and then later, like, it is not a big city. But when you're a kid, your whole perspective of what is big and not is so drastically different than when you're an adult.
Absolutely. Now, did they live on a farm in West Virginia or?
No, they lived at the bottom of this steep hill. I have no idea how they lived in that place. But then it just was getting flooded too much. So, yep.
Not cool, I know.
Mm.
Yeah, I've been through West Virginia more than once. So I
And
can
there are just lots and lots and lots of hills. That's all I can say.
in your career now, you have mentioned advocating for those that can't advocate for themselves. Let's talk about that because I think education is so vital for people to know what their rights are and what, help them understand what they can do and what someone like yourself can assist with. So yeah, let's talk about that. I think you need to educate some folks here, including me.
So when I was in my PhD and my postdoc, I never thought I'd be doing a career in patient advocacy. It just wasn't on my radar, even though I've been a caregiver for my grandparents and, in essence, providing caregiving for my mother while I was living here. But what I saw a lot of is, just how my mom would routinely get ignored in the healthcare settings. They would be told, oh, well, the readout is in my chart, but my mom didn't have a computer, didn't have a phone. So if you're going to tell them it's in my chart, one, they're not going to be able to print it. Two, you're going to make them read jargon and maybe get to page 6 on what they need to do. And so I think sometimes providers have gotten so used to just, oh, it's in my chart, but not everyone uses it. And you still need to take the time to explain these things to your patients so they can understand it. And then, and I just saw a lot of that. And then as I transitioned and I worked at the American Association for Cancer Research and then Lung Cancer Research Foundation and then Longevity. And at LCR, patients started reaching out to me to ask me to speak about lung cancer disparities and the things that impact Black and Hispanic patients. And it's ironic because my PhD was in lung cancer. I started my PhD in 2003. And when I started, I'll try not to get too technical. The biomarker EGFR had just been discovered. And that, I wasn't even studying that. It was just that we've come so far in the last 20 years since then, as far as biomarkers and early detection. But my PhD was in lung cancer, but I wasn't thinking about biomarkers. We weren't thinking about disparities at the time. But now as we've gone 20 years later, we see there's just massive disparities across the board. Lung cancer is still the leading cause of cancer death and incidence. And it gets way less funding than breast, prostate, and colon cancer. It still gets less than all of those combined. But the issue is there's a lot of stigma associated with lung cancer. Those anti-smoking campaigns in the 80s were really, really strong at, making you see people that have a history of smoking as somehow evil or deserving of cancer, and people have somehow associated those strong images with, well, if you have lung cancer, you must be a person that smokes, and that is not remotely true. While maybe 65% of lung cancer can be due to a history of smoking, there are other risk factors like indoor cooking modules, radon, air pollution, job exposures, machining, firefighters. There's even the whole big population of Asian females with no history of smoking that somehow still keep getting lung cancer, and we do not know why.
Wow.
But the second leading cause of lung cancer is radon.
Wow.
Yes.
That's amazing because you do associate lung cancer with smoking. I've got siblings that smoke. And of course, my brother now he's got throat cancer. Not so much in his lungs, but he smoked for 50 years. I don't know, 40 some. And while that, I know that does break the body down significantly, it's good to know that, and it's sad that people get put in that category and treated like, less than. I had no idea that lung cancer was at a higher ratio than breast cancer and some of these others.
Yes, it is the leading cause of cancer death in the U.S., and I believe leading cause of cancer death worldwide as well.
That is crazy. And so what are you doing to educate the world besides being on podcast and that type of thing? What is your part to help open the eyes of the people out there to see just how much it is an issue and to help reverse this stigma? I'm sure you're making an impact.
Yeah, well, stigma is one of the biggest issues, related to stigma is nihilism and fatalism. One is that you believe that you deserve to get it, and so nothing matters. Another one is that no matter what you do, you're going to die. And so we're working to try to change the language around communicating about lung cancer and lung cancer risk factors. I'm on the National Lung Cancer Roundtable Stigma and Nihilism Task Force and Health Equity Task Forces. But the Stigma and Nihilism Task Force main purpose is to really work on ways to address stigma and nihilism through education campaigns, through materials, through resources, and we try to champion the use of lung cancer screening. Because right now we do have lung cancer screening that really came into play around 2013. Before then, we did not have lung cancer screening, but after 2013, we had a couple of big trials that showed low dose computed tomography was able to effectively pick up lung cancer at earlier stages. So you could pick up maybe 1 to 2 stages earlier. And if you can catch it early, you had a much greater chance of survival. The only downside of lung cancer screening, not that the screening is bad, is that you still have to have a risk factor to be eligible for screening. So you have to be, I believe now it's between 50 and 70, and you have to have a 20-pack year smoking history. And you have to, and so that means you have to be a high risk patient. So screening is really for those that have a history of smoking. And while we're on a pack year history, since that's hard to define, think of it, a pack year is really defined as if you smoke a pack of cigarettes a day for a year, that is a pack year.
Wow.
So
Yeah.
if you smoke for 10 years a pack a day, that's a 10, so you hit 10 pack year history. 20 is you do 20 packs a day. I mean, 20, Lord, if you do 20 packs, that's a lot of trouble. You do 2 packs a day for 5 years, you hit the same number. So the threshold is no matter how you get there or how many years, that is what makes you eligible for screening. And then if you meet the screening guideline, and even if you have quit within the last 10 to 15 years, you're still eligible for a low dose CT. And low dose CT is you lay in a flatbed scanner. It takes less than 5 minutes. And then they're trying to look to see if there are any nodules or abnormalities in the lung. And then if they are, then they would do follow-up work. And then because you have a high history, you're supposed to follow up at least 2 more consecutive years.
Wow. Now, how about coal miners and people because your parents were in West Virginia. So I imagine coal mining has come into play on that some.
Oh, that is a major issue as well. Specifically coal miners, people that are like places like Kentucky where there's a lot of radon. And what people don't realize is actually also in Kentucky, in the process of distilling, I believe it's the bourbon. It goes over that limestone. The process goes over and it leaches more radon out. So there's a lot more radon in Kentucky, but there's other places like Pennsylvania has some high levels of radon. And the thing is, radon, indoor cooking modules, firefighter, those are not even part of the guidelines. The guidelines literally only say history of smoking. But if you have a good program set up, you can include these other known risk factors as part of your screening program, but you have to do that at the beginning. You can't just offshoot, do 1 or 2. You have to incorporate it into the guidelines and for your center to get them covered.
Yeah, well, I live in Oregon, and of course, right now we have the nation's largest wildfire going on. So that is a big issue, and it's akin to where I live. I've gotten a lot of secondhand smoke. You can close your windows, you can do everything, and you're still going to have it seep through. And firefighters are really, I would think,
yes,
high risk.
Yes, they are. They're high risk. I spent 3.5 years in Oregon.
Okay.
It was, you either have rain season or you have fire season. I mean, I'm not even joking, but it was.
I know. I told somebody that last year. I said, yeah, it's fire season. And she said, it has its own season. I'm like, yeah, it does. Out here, it definitely does. And I know California is prone to them and Washington and stuff, but Oregon, where I am, it's high desert, a lot of high desert area, but then you've got the mountains and you've got a lot of forest. And so our poor firefighters, I mean, they can only wear so much gear. They're out in the heat and they're getting that smoke too. Wow.
And I think the Science Museum is at OMSI right there in downtown in Portland. They had a whole display about fire and fire history, or did I see a presentation? But unfortunately, it seems like there's been a decoupling between the weather and the amount of forestation. So it seems like there'll be some more exacerbated fires in the future, which is unfortunate.
Yeah, yeah, absolutely. And not enough rain to, and then if you get the lightning strikes, then you're still got the
Yep.
risk of more
Yep.
fires. Yeah. Yeah, so you're doing some really good work in these areas. What else are you driven to make a difference at? And in patient advocacy, I think I'd like to address directly to on your end because the people navigating things like Medicare and Medicaid. Oh my gosh, I had a little experience with my mother, and I was like, my sister took it over, and I'm like, shoo,
Yes.
navigating that stuff. So, can you give some wise advice to our audience and helpful tips and anything you can
Yeah.
help?
Yeah. My mother was on Medicare. I think my grandmother and I have been on Medicaid for the last year and a half. I know, yes, the PhD is on Medicaid. No, well, you don't really know the reason, but the real reason is only because I launched the nonprofit, and so I have no salary because I've been trying to build the org. That's the only reason I'm on Medicaid. Not that being on Medicaid is good or bad. Like, when you need it, you need it. But it can provide some beneficial services. But when you're on Medicaid, you have a lot of paperwork to deal with and navigating healthcare and then waiting for approvals. And then things can take forever when you don't need them to. I learned I'm on Medicaid. When I had reconstructive surgery of my foot, and after I got out of the hospital, I was told, okay, I have to go pick up my new prescriptions, and I needed the pain meds. I did not make it to the pharmacy because I fell, and I'm like, and then I tried to call the Walgreens, and I was going to try to get prescription delivery because they do have that option. You can get your prescriptions delivered. However, that is not an option when you're on Medicaid.
No way. That
Yep.
that
So
that's prejudicial.
I don't think it's per se the stores. I think there's a rule in Medicaid that you can't get mail order prescriptions, even though I was in no condition to walk or go. So I had to wait for a friend to go pick up prescriptions. And I just think part of this is steeped in, well, they believe if you're getting mail order that you're going to abuse the system, if you're going to try to get narcotics, which I didn't need to get to. But they always, sometimes the system is set up to assume you are guilty when you've done no wrong, and it's much harder to overcome that.
Wow.
But yeah, but Medicaid, the other thing Medicaid does offer is if you have a reconstructive surgery or a major procedure, which I did not know about at the time, is you can have something they have medical assisted transport or MAS. I think it's across the country. And if you have MAS, you can call to get a taxi to transport you to and from your appointments.
Good to
The
know.
bonus is it will help get you to your appointment, especially if you really can't move. The downside is they don't have one fixed vendor. So you have to still call a taxi place 2 days in advance. And even though you call in advance and they tell you to, and they'll call you the day before to confirm, the day of your appointment comes up, they may not show up on time. They may not show up at all. I had this happen twice, like 3 times. I had my pickup not show up twice, and I waited more than an hour. So you know what? At this point, I can somewhat ambulate. I wasn't, but I said I'm going to take the subway or a bus because I'm not waiting any longer. So even though you have the services, if you need, you may have to call 4 hours in advance to pick up because you just never know who's going to come and if they're going to be on time. And I've seen plenty of people, I was late for an appointment because the place that was supposed to be up, they just didn't show up and they didn't tell me and they just sent the ride back into the system. And I'm like, and this was the morning of my appointment. So I ended up, I can't miss this appointment because it's hard to get appointments with orthopedic surgeon. It really is. So they sent another transfer. I was about an hour late. I just like, please let me get in here. But they let me in. But if that happened to me and I know how to navigate, then what has happened to all these other poor, underserved patients who don't know how to navigate and don't know, and then they get frustrated because they never can get picked up. And then if you don't show up at appointments, you're considered non-compliant or late, and then you get kicked off. Or let's say you are working 3 jobs and you're trying to make it, but you don't have an appointment at a time that can work with your schedule, or you're in a job, you have one of these front-facing jobs that don't pay a lot, but you can't afford to miss work, which is things people with good insurance and good jobs don't ever worry about. But when you are poor, you have many other things you're juggling, and you still have to somehow show up, and then you're labeled as non-compliant when a lot of things is life, and they don't account for that. Did I give enough, or did I need to go more? I'm sorry. I didn't go on a tangent, but I don't know if I got to what you needed me
No,
to talk.
no, that's fine. Are there services that can advocate for the people that are underserved that you were talking about?
So there's the MAS, which is your main transport. Through Medicaid, they typically do have a list of local social service organizations, but you will have to go making a few calls yourself and finding them. I should have used them more, but I didn't think I'd still be on Medicaid, so I did not. And that wasn't about me being stubborn. It was just I didn't think I'd still be on Medicaid, and then I still feel bad. Like, yes, I need this stuff, but like I know people need it more than me, which is hard when I really did need it. But I'm just that kind of person.
Well, I'm wondering if because I had a client, still do, that provides medical insurance billing. Now, the insurance is a monster. Insurance is an absolute monster. Not to mention the Medicaid, Medicare stuff. Throw it all in one pile and it will drive anybody out of their mind. But I'm wondering, are there individuals that can help people that don't know how to navigate the insurance, the Medicare, Medicaid? Are there companies or businesses that do that?
Sometimes there are local businesses that will help patients navigate, but you kind of have to go looking for them. They don't always readily advertise what they do, because it can still be hard as a patient because everything is a prior authorization, everything is a wait, and you can get frustrated very, very easily because you're trying to do the best you can, and everything is a hold up or a pause, or we gotta put you on hold for 30 minutes, and you're just like, really? So, but there's social services, typically food pantries. Sometimes they have a set day or time where you can pick up food for free, and there's social workers. There's different agencies. I never use the rest of the services, so I can't tell you all of them, but I do know that typically if you're in a hospital, the caseworker usually will give you a list, but then it's still on you to contact these places.
Yeah. Well, that's good because I know the frustration of just dealing with, simply auto insurance, let alone medical insurance. And my client that does medical billings, just like, I was like, how do you do this? She goes, it's constantly changing. Constantly.
Yes.
And
Yes.
yeah.
Yep.
And it all depends too on your insurance company, doesn't it?
Oh my God, yes. Blue Cross, Aetna, Cigna, all of them. They all have pros and cons, except the big thing is usually when you need them is when they will tell you, no, we're not going to cover that. Or the worst, this is not necessarily a Medicaid thing, is when you're on a medication that actually works, and then you get we're not going to cover this specific diabetes medication anymore, or we're not going to cover that ADHD med because we don't want to. And it's like, but this is the one that actually works. And so when you force people off something that works, the outcome is usually never good because then they're trying to use suboptimal things. And it's even worse for cancer patients because when they get that denial, even though there's clear medical evidence that they need treatment X, but then you're in a battle with the insurance or their auto agent now, which is now doing automated, denials, and everything is often about how much we don't want to pay out as opposed to how we can help patients. So you really have to stay on top of stuff, which is really hard when you're already trying to deal often when you're vulnerable and you don't know something, you don't even know who to talk to.
Right. And then you're not feeling good on top of all of that.
Yep. And then there's extra stress and pressure. And then, and then you're still worried about money, food, and you have a whole lot of other things.
You sure do. How are you assisting people in other ways? Is there anything else you would like to discuss about? Because you're doing so much in so many areas and you've dealt with enough of your own challenges.
So, the big thing, we do besides we run an annual lung cancer intervention summit.
Mm-hmm.
It's primarily focused on solutions that are reducing disparities, reducing inequities, and or improving outcomes. It is not solely a disparities conference, but we try to focus on the needs of Black and Hispanic and other underserved patients navigating lung cancer, because these patients tend to not really get seen or are seen at the larger organizations. They may go to the meetups, but they still don't get the same information. They may go to the meetups, but the other patients who tend to not look like them tend to have more money, so they get offered trials and biomarker testing and things that will help increase their survivorship. But when you're poor and underserved, those things typically aren't offered to you. So then how do you engage when you aren't even being treated fairly? There's bias, a lot of bias, some bias from healthcare providers. There's, people often are offered biomarker testing or trials. So part of the goal of the summit is to bring people from different stakeholder groups to not just talk about the problems, because we always do that, but talk about the solutions that are being created at different levels by all the stakeholders that are actually improving access, improving outcomes, improving survivorship. So that is the one thing we're doing. The second thing is we are really working to increase health literacy and health advocacy. Yeah. So we are working on creating we're trying to make infographics to break down basic medical information, as well as, describe cancer information. And for the cancers, we're just doing a general infographic on a cancer and then one disparity in that cancer. It's not the end all, it's just laying the foundational materials. Okay. And then next year or so, we'll start building out likely the lung cancer stuff first, and then we'll go to the other cancers. We're trying to make sure that patients see materials, understand it, and they also see that diverse representation, because they often don't see this in infographics and materials. And if you're for someone from an underserved community, oh my God, this person looks like me, whether they're animated or real, then you're like, okay, I might actually pay attention. I might actually find something. And we try to bring diverse people working across these sectors in, because what you don't want to have is a sort of an intervention summit on solutions, and then you still have no diverse speakers. I'm not, because then that's all we have normally. So you have to intentionally find the people across the country that are passionate about working with these communities, making sure they get educated, and then we're using the summit to start build that community dedicated to helping address the barriers. So we do that, we do the infographics, and we are now we started 2 webinars on lung cancer, and we will be launching probably in the next month or 2, a STEM podcast really highlighting diverse individuals and their pathways, so the kids can see people that look like them at early ages, because we need to inspire these kids so they know they can go into STEM fields, because if you wait for society, you'll get told what you can't do. And then we're working on something about entrepreneurship in cancer, and we're still planning that out. Excellent. So that's sort of high level what we're doing.
Now, this information everything that you want to provide for our audience will be at the end of this podcast. And is that summit something that the public can attend, and is it virtual?
It can be attended by the public, but it is in person. It'll be at the University of Illinois, Chicago. Okay. We will be using the Hoover, the event platform. Even though we'll be using a platform, we're just using that to set the agenda up. I can send you the links to the agenda. I can send you the links to the registration page. If you're in Chicago, the summit is free for patients, caregivers, and survivors. That's the one thing. We try to keep it free for those, and then we scale up in price for everyone else. And the goal is to because the patients already are missing a lot of information. So we want to put them in a position to learn more about the disease, learn how to advocate, and learn who is working on their behalf, and then these other stakeholders to, see the room with people that really need their information, possibly learn best practices they can implement. And then by bringing both groups together, we break down these silos, because typically we will have only a patient event or only a researcher event or only a clinician event. And those are different audiences, and then you have different messaging. But if you don't bring them all together, then they don't see each other. So that's the goal of the summit.
Fantastic. And it'd be nice if it was virtual, but that's a lot of work too. So
yes, I know. It's like maybe in a year or two when we have the program where it's sustainable, we're still building it. When we have, a robust in-person attendance and we can scale, like I think next year will be the first year we'll finally be able to hold it in a hotel.
okay.
Which means it'll be growing. And so that'll be good. And then, then at that point, we'll have more ability to possibly do a virtual component, because then we'll have, we'll have the bandwidth and the spacing in AV that we can set up.
That sounds great. And I'm sure there's people that could work on sponsoring something like this to provide more revenue. Well, we're going to wrap it up. We've been going a little over a half hour, and I want to know any final words that you might have for our wonderful audience. And again, we'll have all your information available. But what parting words would you like to give to encourage our Courage, Confidence, Connections audience?
I want to let people know, believe in what you're doing. Don't be afraid to be different. And especially if you're navigating healthcare, understand you have a right to your medical records. Make sure you read your medical records. Make sure if you can't read them, have someone else that reads them to make sure they accurately say what state you're in and what you can do, because you don't want to get stuck with someone lying in your medical records and that impacting downstream care. I've seen it personally. And so you want to make sure you have people that can read and advocate. And then if you are not getting the things you need, make sure you know how to contact hospital leadership with certified letters. Make sure if it's a Joint Commission accredited hospital, know how to write them. Make sure you can file complaints with insurance. Make sure you can also file with Office of Professional Discipline if you feel a healthcare provider has given you neglectful care. So those are the key takeaways, and just keep believing in what you're doing, and that if anything goes wrong, it's usually not your fault. It's the way society is just set up to make you believe it is.
Absolutely. And great wisdom there. Lots of information for our audience. So you'll be hearing from some, I'm sure. And I want to thank our audience. Thank you again, Eugene, for joining us, Dr. Eugene Manley. And we'll be back with another Courage, Confidence, and Connections podcast in the near future. Stay tuned.
Thank you so much for having me. It was a pleasure.
All right. Thank you.